When we first start our medical training, we're kind of seduced by this illusion of localized disease.
Absolutely. We really are.
Yeah, there's this expectation of mechanical precision, almost like engineering. A patient comes in, they have a fractured radius, you order the x-ray, the film goes up on the light box, and you see that jagged white line.
Right. And the attending just points at it and says, there it is. Fix the bone, fix the patient.
Exactly. It's broken or it's not broken, lacerated or intact.
It is deeply comforting, isn't it? I mean, we crave things that are binary and visible like that. We like things easily categorized into a single organ system because, well, it makes us feel in control.
It really does.
Yeah.
But then you progress in your training and you step into the real world of complex systemic physiology. Specifically, you step into the realm of obstetric anesthesia.
Oh, yeah, that's a whole different ballgame.
Right. You're subtly managing a patient with severe decompensating cardiac disease, and all of a sudden, that comforting x-ray machine is completely useless.
Completely. Because the pathology isn't a single broken bone anymore. It's a dynamic, terrifying cascade of hemodynamic dominoes.
Yeah, we're no longer looking at a localized problem at all. We are staring down a diagnostic and management landscape that is, quite honestly, incredibly murky.
It is the absolute definition of diagnostic muddy waters. And, navigating those waters requires a level of synthesis that goes far, far beyond basic medical school knowledge.
Definitely.
You can't just be an anesthesiologist in that room. You must simultaneously be a cardiologist, an obstetrician, a neonatologist, and an intensive care specialist all at once.
And that is exactly why we are here today. We are talking directly to you. Yes, you. The dedicated MD anesthesiology student currently preparing for the formidable Gujarat University exams.
We know exactly what you're going through right now.
We really do. You're staring down those 20-mark long case questions. You're anticipating the Viva traps where the external examiner is just waiting for you to say the wrong drug.
Oh, they love doing that.
Right. And you're running through the OSCE stations in your head. It can feel completely overwhelming. So the mission of this deep dive is laser-focused. Okay, let's unpack this. We are going to completely master the management of cardiac patients for non-cardiac surgery, with a really special emphasis on mitral stenosis, or MS, in pregnancy.
It's a phenomenal topic, and let me tell you, as someone who actually sits on the other side of that exam table, it is a frequent favorite of examiners.
Oh, I bet. Why is it such a favorite?
Because it ruthlessly tests your ability to balance fiercely competing physiological demands. I mean, it tests if you truly understand the why behind the medicine, not just the what.
Right. It's not just a memory game.
Exactly. My goal for our time together is to be that senior faculty mentor for you. I want to set a calm, authoritative, but, entirely supportive tone. I want to emphasize that passing this exam, and infinitely more importantly, becoming a safe, exceptional consultant, isn't about rote memorization.
It's about clinical reasoning.
Precisely. You need to synthesize these disciplines, impress the examiners with your logic, and ultimately keep both the mother and the baby alive.
To do that, we have pulled together a massive stack of definitive sources to get you ready. We're integrating the Anesthesia Review course, the ARC textbook, the compilation of DNB questions, Miller's Anesthesia, and long and short cases in anesthesiology.
That's the gold standard stack right there.
It really is. We're going to distill all of this into pure, actionable physiological logic. So let's start by looking at the sheer burden of cardiac disease in surgical patients. I think sometimes as students, we view severe cardiac disease as this rare zebra.
Like a once-in-a-career case.
Yeah, exactly. Oh, I might see this once a year. I just need to memorize it for the test and then forget it.
That is a very dangerous misconception. The burden of cardiac disease encountered in surgical wards is staggering, and frankly, it's growing every single day.
What do the numbers actually look like?
Well, when we look at the epidemiological data, major adverse cardiac events, or MACE-E, represent a leading cause of perioperative mortality globally.
Wow.
Yeah, as our population ages, as we see exploding rates of metabolic syndrome, diabetes, and hypertension, and, in many populations, a persistent tragic burden of rheumatic heart disease, the volume of patients presenting to your operating theater with profoundly compromised cardiovascular systems is only going up.
So you will deal with this every week.
Every single week.
Which makes our preoperative cardiac risk assessment so incredibly vital. When I look at the exam questions, the examiner isn't just asking how you induce anesthesia, right?
No, not at all.
They're testing whether you, the student, can foresee and mitigate a hemodynamic disaster
Yeah.
days or even hours before the patient hits the operating table.
Precisely. The examiner wants to see you look at a patient and mentally run a simulation. You aren't just putting them to sleep.
You're managing a stress test.
Yes. A controlled physiological stress test. Surgery itself is trauma. It induces massive fluid shifts, pain, catecholamine surges, and varying degrees of hypoxia and hypercarbia.
Right.
The core question is, can this specific heart withstand that specific stress test? That is the question you must answer before you ever pick up a syringe.
And then we take that surgical stress test and we layer pregnancy on top of it. I know we often say pregnancy is a marathon, but let's actually break down the physiology of why that is.
It's a great analogy.
It's essentially asking the cardiovascular system to run a continuous 9-month marathon, but at a sprinter's pace.
Let's quantify that marathon because, the examiners love the specific number.
Yes, give us the numbers.
Over the course of a normal pregnancy, the maternal blood volume increases by roughly 40 to 50%.
It's a massive volume load.
It is. The red blood cell mass increases, but the plasma volume increases significantly more, which leads to that classic physiological anemia of pregnancy.
Right, the hemodilution effect.
Exactly. Now, to handle this massive extra volume, the maternal heart rate climbs by 10 to 20 beats per minute. Ultimately, the cardiac output goes up by up to 50% by the late second trimester.
Wow, 50%.
Meanwhile, the systemic vascular resistance, the SVR, drops significantly due to the vasodilatory effects of progesterone and the creation of the low-resistance uteroplacental bed.
Okay, so I want to pause right here because this is the absolute crux of the entire topic.
It really is.
We have a state, pregnancy, that demands a 50% increase in cardiac output. Now, introduce a narrowed stenotic mitral valve into that exact system.
Yeah.
Why is that specifically so catastrophic?
Because mitral stenosis creates a fixed cardiac output.
A fixed output.
Yes. The left ventricle, no matter how hard it tries, can only pump out the volume of blood that can physically squeeze its way through that tight, calcified stenotic mitral valve during diastole. It's a mechanical obstruction.
Right, it's blocked.
So when the pregnancy marathon demands more and more output, the heart simply cannot deliver it. The forward flow is physically restricted.
And all that extra pregnant blood volume can't get into the left ventricle, so it has to go somewhere.
Exactly. It backs up. It causes a critical, dangerous buildup of pressure into the left atrium, retrograde into the pulmonary veins, and eventually floods the pulmonary capillaries.
And this is exactly how it shows up in the exam. You're going to see these 10 to 20 mark long questions, or you'll get a clinical scenario handed to you in a Viva.
Oh, absolutely.
A classic DNB question we saw in the sources is straightforward but terrifying. Quote, discuss the anesthetic management of a 30-year-old premic with severe MS for elective LSCS, end quote.
It is the quintessential obstetric anesthesia nightmare scenario. And I'll tell you, it perfectly separates the rote memorizers from the true clinicians.
I always get tripped up on the timeline here, though. If the heart is working overtime from day one of the pregnancy, why does the real danger, the sudden onset of severe dyspnea, orthopnea, and overt decompensation, so frequently strike specifically in the second trimester?
That's a great question.
Why not at the very end when they're the heaviest and largest?
What's fascinating here is the precise, nonlinear timeline of maternal hemodynamics. The physiological stress, specifically that aggressive rise in blood volume and cardiac output, it doesn't just trickle up slowly over 9 months.
Oh, it doesn't too.
No, it ramps up aggressively and hits its absolute peak velocity between the 20th and 24th week of gestation.
Oh.
Right in that 3rd to 5th month window. That is the moment when the physiological demand suddenly outstrips the fixed, limited supply of the stenotic valve.
So the heart could compensate early on, but it just hits a wall.
Exactly. The heart could compensate during the first trimester, but that second trimester surge pushes the pulmonary capillary hydrostatic pressure over the edge. The fluid leaks into the alveoli, and they tip over into frank pulmonary edema.
That makes total sense now. Okay, so before we even touch the pregnant patient with MS, the examiners demand that we show mastery of the general approach to any cardiac patient.
This is the foundation.
Right. If you mess this up, you fail the case before you even mention the mitral valve. Let's talk preoperative cardiac risk assessment. How do we objectively measure their reserve?
We start with functional status, which is universally measured in metabolic equivalence, or MEET.
MEETs. Okay.
And this isn't just a number to memorize. It is a highly practical bedside measure of cardiopulmonary reserve. 1 MA is the resting oxygen consumption of a 40-year-old man, roughly 3.5 milliliters of oxygen per kilogram per minute.
But you don't calculate that in the ward, right?
Right.
Like with a calculator.
No, of course not. You ask practical questions. Can the patient independently dress themselves? That is about two main T's. Can they climb a flight of stairs or walk up a hill without stopping due to dyspnea or chest pain?
And that stair question is the golden ticket, right? That equates to 4
Oh,
MACEs.
exactly. 4 MACEs is the critical threshold. If a patient can achieve 4 MACEs of exertion without symptoms, their statistical risk for perioperative major adverse cardiac events is relatively low. But if they cannot achieve 4 MACEs, if they get breathless just walking around the house, their risk profile rises sharply, and you must escalate your preoperative evaluation.
We also have the ASA physical status classification, of course. We adjust it upward when systemic cardiac disease is present, usually an ASA 3 or 4V, depending on how limiting the disease is.
Right.
But where the examiners really want to see you shine, where you show that high-level synthesis, is your understanding of the risk indices.
Yes, the Goldman Cardiac Risk Index and its modern successor, the Revised Cardiac Risk Index, or RCRI, these are conceptual frameworks you absolutely must master.
Essential for the written exam.
But listen carefully. It's not just about memorizing the names of the scores. The examiner wants to know if you understand why the specific points in these indices carry so much weight.
Right, let's look at the pathophysiological backing for these. For instance, a history of myocardial infarction, especially within the last 6 months, or the presence of pathological Q waves on the preoperative ECG. Why are those such major red flags?
Because a recent MI means the myocardium is still in a state of healing and heightened irritability. The scar tissue is electrically unstable, massively increasing the risk of perioperative ventricular arrhythmias.
It's like a ticking time bomb.
It is. Furthermore, the viable tissue surrounding the infarct is often ischemic and relying on fragile collateral circulation. When you subject that heart to the hemodynamic swings of anesthesia, hypotension, tachycardia, sympathetic surges, that fragile collateral flow fails, and you convert a previous infarct into a fresh, lethal one.
The sources also point out that finding an S3 gallop or jugular venous distension during your physical exam screams congestive heart failure.
Yeah.
And that carries massive weight on the index.
Absolutely. An S3 gallop is the sound of blood hitting a stiff, overfilled, failing left ventricle. JVD indicates right-sided backup.
Right.
And a history of pulmonary edema, especially within the previous 7 days, is heavily weighted because it means the patient's compensatory mechanisms have already failed. They're teetering on the edge of the cliff.
Any small push sends them over.
Exactly. Significant aortic stenosis with a pressure gradient greater than 50 millimeters of mercury is another massive risk factor, which we'll compare to MS later. And of course, arrhythmias.
What kind of arrhythmias?
Any rhythm other than sinus or the presence of more than 5 premature ventricular contractions, PVCs, per minute documented before surgery. That indicates extreme electrical instability.
We had to balance all of those intrinsic patient factors against the extrinsic nature of the surgery itself.
Correct. Risk is an interception. You must distinguish between low, intermediate, and high-risk surgical procedures.
Right.
A superficial surgery, like a cataract extraction or a breast biopsy, is low risk. The fluid shifts are minimal, the sympathetic stress is low. An intraperitoneal or intrathoracic surgery, like a bowel resection, is intermediate risk.
But major vascular surgery, like an open aortic aneurysm repair, is high risk.
High risk because of the massive, unavoidable fluid shifts, the potential for colossal blood loss, and the application and removal of cross clamps that cause violent swings in systemic vascular resistance.
All right, the plumbing just gets totally disrupted.
Completely. The depth of your cardiac evaluation, whether you proceed, whether you order stress tests, whether you cancel the case, is dictated entirely by the intersection of the patient's RCRI score and that surgical risk category.
So for you, the student listening, here is the examiner-oriented approach. When you are sitting in the exam hall staring at the blank paper, structure your assessment logically to show this exact thought process.
Yes, structure is everything.
Start with the history to establish METs. Move to the physical exam, explicitly stating you were looking for that S3 or JVD. Then list the specific RCRI factors present in the clinical vignette.
Beautiful.
Classify the surgical risk based on the proposed procedure. And finally, conclude with a synthesized plan. State whether further testing, like an echocardiogram, is needed based on that specific matrix.
That structure proves you are thinking like a consultant. It will score you maximum points every single time.
Let's transition to the optimization phase.
Yeah.
If a patient comes in with heart failure or arrhythmias, we obviously don't just roll them into the operating room and hope for the best.
Never. Optimization is where lives are saved. You must optimize fluid status and control the ventricular rate before induction.
With this stage.
If they are in rapid atrial fibrillation, you have to control that rate pharmacologically. We will discuss why tachycardia is deadly in stenotic lesions shortly, but if you induce a patient with a heart rate of 130 in AFib, you are inviting cardiac arrest.
We also have crucial anticoagulation considerations. Cardiac patients are often on blood thinners, and pregnant cardiac patients even more so. The texts spend a lot of time on low molecular weight heparin, or LMWH, like enoxaparin.
They do.
And there are strict golden exam rules here regarding neuraxial anesthesia.
Very strict and highly tested, because making a mistake here causes irreversible harm. Let's look at the cellular and physical reality of the epidural space.
Okay, let's visualize it.
It is a potential space filled with fat, areolar tissue, and a dense, engorged network of veins called the venous plexus of Batson. When you introduce a needle or a catheter into that space, you will frequently nick one of those veins.
Which is normally fine, right?
In a normal patient, yes, the coagulation cascade seals it instantly. But in a patient on LMWH, they bleed into that confined space.
And that creates the spinal epidural hematoma.
Exactly. The hematoma expands and it has nowhere to go because of the rigid, bony spinal canal, so it compresses the spinal cord. The patient develops profound ischemia of the cord and is paralyzed for life.
Oh.
That is the disaster you are actively preventing by knowing the timing rules. You must wait a minimum of 12 hours after a prophylactic dose of LMWH before you can safely perform any neuraxial intervention, be it a spinal or an epidural.
12 hours for prophylactic.
Yes. For therapeutic doses, that wait time doubles to 24 hours. And crucially, you have to apply these same rigorous timings for the removal of an epidural catheter, ensuring no LMWH is given for at least 2 hours after the catheter is pulled.
Got it. And what about their daily cardiac medications? The beta blockers, the statins. Do we hold those because they might cause hypotension under anesthesia?
That used to be a debate decades ago, but the modern golden rule is absolute continuation.
Oh, really? Don't stop them at all?
Do not stop them. Beta blockers, statins, and most antihypertensives should be continued right through the perioperative period, including the morning of surgery, with a tiny sip of water.
Why is that?
If you abruptly withdraw a beta blocker, the patient experiences severe receptor upregulation and rebound tachycardia, which drives myocardial ischemia. You keep them on their meds.
Okay, let's step into the operating theater. This brings us to the core anesthetic principles for cardiac patients, the absolute exam gold. The core mantra I see repeated in every textbook is maintain hemodynamic stability.
Right.
But, what does that actually mean? It sounds like a platitude.
It does sound vague, doesn't it? But clinically, it has a very specific metric. Maintaining hemodynamic stability means keeping the patient's heart rate and blood pressure within 20% of their normal awake baseline values.
Wow. The 20% rule.
Yes. If their normal systolic is 110, you don't let it drop below 88 or rise above 132. You defend that 20% window aggressively.
And within that window, the twin demons we are fighting are tachycardia and hypotension. I really want to drill down on why tachycardia is so incredibly dangerous.
Please do.
Because in a normal person running for a bus, a heart rate of 120 is totally fine. Why is it a death sentence for a cardiac patient, especially one with a stenotic valve?
To understand this, we have to look at the cardiac cycle. The heart is the only organ in the body that perfuses itself almost entirely during diastole, the relaxation phase.
Only during relaxation.
Right. During systole, when the heart muscle contracts, the pressure inside the left ventricular wall is so massive that it physically squeezes the coronary arteries shut. Blood cannot flow to the spendocardium. It's only when the heart relaxes during diastole that the aortic root pressure pushes oxygenated blood into the coronaries to feed the heart muscle.
Right. And here's the math problem. If the heart rate goes from 60 to 120, the time it takes for the heart to contract systole stays relatively fixed. It takes a certain amount of milliseconds for the muscle fibers to depolarize and squeeze.
Exactly.
So if the overall beat is faster, all that lost time comes directly out of diastole.
Precisely. Tachycardia drastically reduces diastolic filling time. So the heart muscle is beating twice as fast, demanding twice as much oxygen, but the window of time it has to actually receive that oxygen is cut in half.
That's horrifying.
That is the definition of ischemia. Furthermore, in stenotic lesions like mitral stenosis, the blood needs that long diastolic period to physically force its way through the narrow valve into the ventricle. If you cut diastole short, the left ventricle sits empty. Output drops to zero.
We also need to optimize preload, afterload, and contractility. We often hear the plumbing analogy, right? The pump, the tank, the pipes. But for a postgraduate level, let's elevate that. We are essentially managing a highly reactive, closed-loop hydraulic system with variable resistors.
I vastly prefer that conceptualization. The preload is the end diastolic volume, the stretch on the myocardial fibers just before they contract.
The Frank-Starling curve.
Yes, you have to maintain enough venous return to achieve optimal stretch according to the Frank-Starling mechanism. But if you overfill the system, especially behind a stricture like a tight mitral valve, the hydrostatic pressure blows out the pulmonary capillaries.
And the afterload.
The afterload is the systemic vascular resistance. If the resistor is too tight, the failing pump cannot overcome the pressure to generate forward flow. If the resistor is too loose, the diastolic pressure in the aorta drops. And as we just established, you lose your driving pressure for coronary perfusion.
It's just an agonizing balancing act. And overarching all of this is the need to maintain the oxygen supply-demand balance, ensuring the myocardium gets more oxygen than it consumes.
Critical.
This means avoiding hypoxia and hypercarbia, obviously. But the text also put a huge emphasis on avoiding shivering in the postoperative period. Why is shivering such a big deal?
Because visible shivering is a sign of massive, uncoordinated skeletal muscle contraction. It can increase total body oxygen consumption by up to 400%.
400%.
Yes, the heart has to drastically increase cardiac output to deliver oxygen to those shivering muscles. A compromised heart simply cannot meet that demand, and it will suffer a catastrophic ischemic injury trying to keep up. Keep your patients warm.
So what does this all mean? If you get a question on general cardiac anesthetic goals, your sophisticated examiner-oriented checklist is 1. Defend the 20% baseline window for heart rate and blood pressure.
Good.
2. Aggressively prevent tachycardia to preserve diastolic coronary perfusion and ventricular filling time. 3. Balance the hydraulic system, optimize preload without causing congestion, and maintain SVR to drive coronary flow.
Yes.
And 4, keep the heart drowning in oxygen while minimizing its metabolic work by preventing sympathetic surges and shivering.
If you write that in your exam, you prove you understand the physiology. That's exactly what we want to see.
Let's talk about how we actually monitor all of this intraoperatively.
Yeah.
Standard monitoring is your basic ECG, pulse oximetry, non-invasive blood pressure, and end-tidal CO2. But the texts specifically instruct us on which ECG leads to watch. It's not just a random selection.
No, lead selection is critical. The examiner wants to see that you know what you are looking for. Lead 2 is excellent for diagnosing arrhythmias because its electrical axis looks directly down the line of the atria to the ventricles, showing the P wave beautifully.
But leads 2 is terrible for detecting ischemia, right?
It is terrible for detecting the most common type of perioperative ischemia. For that, you need the precordial leads. Leads V3, V4, or V5 are the most sensitive for detecting anterior and lateral myocardial ischemia. You must explicitly state that you will monitor a 5-lead ECG focusing on V4 or V5 for ST segment depression.
Then we step up to invasive monitoring. We move from the cuff to the arterial line.
An arterial line is absolutely mandatory when you anticipate rapid, life-threatening hemodynamic shifts, or when you are using potent vasoactive infusions, or when you need frequent arterial blood gas sampling.
You can't just wait for the cuff.
You cannot wait 3 minutes for a non-invasive cuff to cycle when the blood pressure is dropping by the second. You need beat-to-beat, real-time arterial pressure.
And a CVP, a central venous pressure line.
A CVP is incredibly useful for trending right-sided heart pressures and guiding your fluid management. It tells you the pressure in the right atrium. It is especially critical when right heart failure is a risk, as the CVP will spike if the right ventricle begins to fail against high pulmonary pressures.
The sources also bring up the role of echocardiography, particularly transesophageal echocardiography, or TE. Now, they don't expect us to be certified echocardiographers, but they do expect us to understand it conceptually.
That's right.
The ARC textbook specifically breaks down M-mode and Doppler. Let's simplify the physics of that.
M-mode stands for motion mode. Imagine sending a single ultra-thin beam of sound down through the heart. M-mode plots the reflections of that single beam over time.
So it's one-dimensional.
Yes, it provides a one-dimensional diagrammatic representation of cardiac structures moving. It is exquisitely precise for timing valve opening and closing, or measuring the exact dimension of the left ventricle at end systole versus end diastole.
And Doppler.
Doppler utilizes the Doppler effect, the change in frequency of a wave, in relation to an observer who is moving relative to the wave source. In this case, the moving source is the red blood cells. Doppler detects the direction and the velocity of moving blood.
Right.
By measuring how fast the blood has to accelerate to get through a narrowed valve, we can use the modified Bernoulli equation to calculate the exact pressure gradient across that stenotic valve. That is how we quantified the severity of the stenosis.
That brings us to the age-old debate. Choice of anesthesia, general versus regional. When a student is asked this, what is the framework?
The framework is understanding that neither is perfect. Both are weapons that can save or kill depending on how they are wielded. Regional anesthesia spinals and epidurals offers excellent opioid-sparing post-operative pain control.
Which is great.
It is a massive advantage because it blunts the sympathetic stress response to pain. However, regional blocks the sympathetic nervous system. A single-shot spinal causes a sudden, profound, uncontrolled sympathectomy.
The SVR just tanks.
The systemic vascular resistance plummets precipitously. In a patient with a fixed cardiac output who relies on SVR to maintain aortic pressure, a spinal can cause a lethal, unrecoverable, hypotensive arrest.
So you might think, okay, I'll just put him to sleep. General anesthesia offers totally controlled oxygenation. I secure the airway. I control the ventilation.
But the act of direct laryngoscopy and passing an endotracheal tube is one of the most intensely stimulating, noxious things you can do to a human being.
It's incredibly stressful.
It causes massive sympathetic surges, explosive tachycardia, and severe hypertension. As we just discussed, tachycardia in these patients is incredibly dangerous. Furthermore, the positive pressure ventilation of GA increases intrathoracic pressure, which impedes venous return, drastically dropping your preload.
So the examiner-oriented decision-making process isn't about dogmatically stating GA is always better or regional is always better.
Never say always.
Right. It's about how you justify your choice by weighing the patient-specific risks, the surgical requirements, and explaining exactly step-by-step how you will mitigate the known physiological downsides of whatever technique you choose.
Precisely. If you choose regional, you must explain how you will prevent the pressure drop, usually by using a slow, graded epidural instead of a spinal, and having vasopressors running. If you choose GA, you must explain the pharmacology of how you will blunt the intubation response before you even open the mouth.
Let's funnel all of this foundational knowledge directly into the core pathology of this deep dive, mitral stenosis. If you don't understand the pathophysiology of MS at a granular level, you cannot pass this case.
You really can't.
Let's look at the basic mechanism. The defining feature is the mechanical obstruction to left ventricular filling. I like the concert hall analogy.
It is an excellent visual. Let's hear it.
Imagine a massive, highly anticipated concert. The grand concert hall is the left ventricle. The eager crowd trying to get in is the oxygenated blood returning from the lungs. A normal mitral valve is like having the entire front wall of the venue completely open. The crowd flows in effortlessly during diastole, filling the hall.
Right.
But a stenotic mitral valve is like taking that wide-open entrance, boarding it up, and chaining the door shut so only the single narrow turnstile is open.
Exactly. A normal mitral valve area is about 4 to 6 square centimeters. The blood flows with virtually no resistance, but as rheumatic fever scars and fuses the commissures of the valve, that area shrinks. When it gets down to 1.5 or 1.0 square centimeters, you have severe stenosis. Only a trickle of blood can get through that turnstile at a time.
And what happens to the massive crowd still trying to get in? They back up. They get crushed against each other outside the door. In the heart, this blood backs up into the left atrium. To force the blood through the narrow opening, the pressure inside the left atrium has to skyrocket. This is the hallmark of the disease. A massive pressure gradient between the left atrium and the left ventricle.
And over months and years, that relentless high pressure physically damages the left atrium. The muscle wall stretches and dilates massively to accommodate the volume.
That causes electrical issues.
Yes. Now, when the atrial tissue stretches, the electrical conduction pathways get distorted and disrupted. This anatomical remodeling is what predisposes the patient to atrial fibrillation. The electrical signals start firing chaotically.
But the backup doesn't stop at the atrium. That high pressure transmits retrogradely backward into the pulmonary veins and eventually into the microscopic pulmonary capillaries in the lungs.
This causes pulmonary congestion. When the hydrostatic pressure in those capillaries exceeds the oncotic pressure of the plasma proteins, fluid is physically forced out of the blood vessels and into the interstitial space of the lungs, and eventually into the alveoli themselves.
They start drowning.
This is pulmonary edema. The patient is literally drowning in their own fluid. Over time, to protect the capillaries from blowing out, the pulmonary arterioles constrict. This creates pulmonary hypertension.
And that's when the right side of the heart gets involved?
Correct. The right ventricle, which is normally a low-pressure, thin-walled pump, suddenly finds itself having to pump blood against this massive pulmonary hypertension. It hypertrophies, it struggles, and eventually it dilates and fails. This is cor pulmonale right heart failure secondary to left-sided pathology.
All the while, let's look back at the left ventricle. Because the blood simply cannot get into it, the cardiac output, the forward flow to the brain, the kidneys, the uterus is severely reduced. The concert hall is mostly empty, even though there's a huge, angry crowd waiting outside.
The anesthetic relevance here is that understanding the specific mechanical and fluid cascade is the key to passing the viva. If you truly grasp the pathophysiology, you don't need to memorize a list of anesthetic goals. They just become logical common sense.
Let's test that logic. Let's go through the hemodynamic goals in mitral stenosis. First goal, maintain sinus rhythm. Why?
Because we need the atrial kick. In a normal heart, the passive flow of blood fills most of the ventricle, and the active contraction of the atrium at the very end of diastole just tops it off. But in MS, the passive flow is choked off by the tight valve.
Right.
The left ventricle becomes utterly reliant on that forceful, coordinated contraction of the atrial kick to forcefully squeeze the blood through the narrow opening.
What happens if they go into AFib?
If the stretched atrium goes into chaotic atrial fibrillation, it just quivers. You lose that kick entirely. In a severe MS patient, losing sinus rhythm can instantly drop cardiac output by 20 to 30%. They will crash in front of you.
Goal 2, avoid tachycardia. We've hammered this, but let's apply it directly to the concert hall.
If the doorway is narrow, the only way to get the crowd inside is to leave the door open for a very long time. Tachycardia shortens diastole. It slams the door shut before the blood can cross the valve. The left ventricle sits empty. Forward output plummets to nothing, and the blood rapidly builds up in the lungs, causing flash pulmonary edema. Keep the heart rate slow. 60 to 80 beats per minute is your target.
Goal 3, maintain preload, but avoid overload and underfilling. It's walking a razor's edge.
You need enough fluid volume, enough pressure from the crowd to push blood across the gradient of the tight valve. If they're hypovolemic, if they're dehydrated or bleeding, the left ventricle gets nothing, and you have intractable hypotension.
But if you give aggressive IV fluids,
If you overfill the system, all that extra fluid just hits the locked door, backs up instantly into the lungs, and you kill them with pulmonary edema. Fluid management must be meticulously titrated, often with the CVP line.
Goal 4, avoid any increase in pulmonary vascular resistance, or PVR. The right heart is already struggling against the pulmonary hypertension. How do we protect it intraoperatively?
By avoiding the physiological triggers that cause pulmonary vasoconstriction. The mnemonic is simple: avoid hypoxia, avoid hypercarbia, avoid acidosis, and avoid hypothermia. Keep the patient warm, meticulously oxygenated, and maintain normal, minute ventilation to blow off CO2.
And lastly, goal 5, maintain systemic vascular resistance.
If you drop the SVR, say, with a heavy bolus of propofol or a deep spinal block, the aortic diastolic pressure drops. Since coronary perfusion relies on that aortic pressure, and the heart is already struggling to pump, the myocardium stops getting oxygen, it becomes ischemic, it fails, and the patient coats.
Maintain sinus rhythm, slow heart rate, precise fluid balance, normal PVR, and maintained SVR. That is your MS mantra. Now we enter the real crucible. We take this fragile, compromised cardiovascular system and we subject it to the ultimate stress test, mitral stenosis in pregnancy.
Here we go.
This is where the marathon meets the locked door. Let's revisit the physiological changes of pregnancy, but now apply them directly to the MS pathology.
We established earlier that pregnancy causes a 50% increase in blood volume and a 40 to 50% increase in cardiac output, driven by an increased heart rate and increased stroke volume.
And we just established that a patient with MS has a strictly fixed cardiac output, cannot tolerate tachycardia, and cannot handle excess volume without going into pulmonary edema.
The anesthetic implications here describe a terrifying, inevitable collision course. You have a physiological state pregnancy that absolutely demands high forward output, high volume, and higher heart rate. Meeting a damaged organ, the MS heart, that has a strictly limited output, cannot tolerate volume, and requires a slow heart rate.
That explains perfectly why MS is so exceptionally high risk in pregnancy. It is the ultimate supply-demand mismatch. The sources give us specific cutoff numbers for the mitral valve area, the MVA, to stratify this risk.
Yes, the examiners look for these exact numbers. As we said, a normal valve is 4 to 6 square centimeters. When the MVA is greater than 1.5 square centimeters, it's considered mild stenosis. These patients generally compensate and have a more favorable pregnancy outcome, though they still require close monitoring.
Right.
But when the MVA drops below 1.0 square centimeter, it is severe MS. This is highly dangerous in pregnancy.
The text mentioned that these severe patients fare much better if they undergo intervention prior to conception, like percutaneous mitral commissurotomy, or PMC, where a balloon is inflated to crack open the stenotic valve.
Ideally, yes.
But often, they present to us already pregnant, unoptimized, and in failure. What are the specific dual threats we are scaring down?
The dual threats are massive pulmonary edema and atrial fibrillation. The 50% increase in maternal blood volume has nowhere to go but backward into the lungs. And that massive volume stretches the left atrium beyond its breaking point, triggering AFib, which loses the atrial kick, which instantly cuts the cardiac output by 30%, worsening the backup even further. It's a vicious cycle.
And we absolutely cannot forget the second patient in the room, the fetal risks.
Right. The fetus relies entirely on maternal blood pressure and maternal oxygenation for placental perfusion. There is no autoregulation in the utero-placental bed. Flow is entirely pressure-dependent.
So if the mom's pressure drops,
Maternal hypoxia from pulmonary edema means immediate fetal hypoxia. Maternal hypotension from poor forward flow means fetal asphyxia. The fetus is the canary in the coal mine for maternal hemodynamics.
so when the examiner asks you to explain the risk, here is your sophisticated explanation. State clearly that the obligate increased volume and heart rate of pregnancy force blood against a fixed stenotic valve, catastrophically raising left atrial pressure and causing pulmonary edema.
Perfect.
Simultaneously, the fixed cardiac output cannot meet the metabolic demands of the growing fetus, leading to uteroplacental insufficiency, hypoxia, and intrauterine growth restriction.
If you can articulate that supply-demand mismatch confidently, using the correct anatomical terms, the examiner will nod, write down a high score, and let you move on to the management phase.
Which brings us to exactly that, anesthetic management of MS in pregnancy. Let's start with preoperative management. We've diagnosed them, now what? First, we assess severity using the New York Heart Association, or NYHA, functional classification.
NYHA Class I means no limitation of physical activity. Class I means symptoms of heart failure at rest. This determines your baseline. Then, multidisciplinary optimization begins immediately. You consult cardiology and obstetrics.
Right.
We must ensure strict pharmacological control of the heart rate. These patients should be carefully titrated on beta blockers like metoprolol to keep that resting heart rate down around 60 to 70 and lengthen diastole.
What about the fluid volume?
Diuretics, like furosemide, are carefully used to manage the increased plasma volume and prevent pulmonary congestion. But again, it's a tightrope. You cannot diurese them so much that you drop their preload and cause hypertension. You use the minimum effective dose.
And anticoagulation considerations reemerge here with a vengeance. Let's look at the pathology. Pregnancy itself is a profoundly hypercoagulable state. The body is increasing clotting factors and decreasing natural anticoagulants to prepare to stop the massive bleeding of childbirth.
Yes, it's a biological defense mechanism.
But when you combine that innate hypercoagulability with a massively dilated left atrium where blood is stagnating and the high risk of atrial fibrillation,
You have the perfect storm for thrombosis. They are at incredibly high risk for deep vein thrombosis, pulmonary embolism, and left atrial clot formation that can embolize and cause a devastating stroke. They must be therapeutically anticoagulated throughout the pregnancy.
which for the anesthesiologist brings us right back to those strict LMWH timing guidelines we discussed earlier.
Yes, you must plan the delivery or the epidural placement around their heparin dosing schedule. You cannot do a spinal on a patient who took therapeutic enoxaparin 10 hours ago.
Let's move to intraoperative management. Very high yield. The patient is rolling into the theater for an elective cesarean section. For monitoring, we want a pre-induction arterial line.
Absolutely. Placing an arterial line after they are asleep and crashing is a fool's errand. You secure it while they are awake. You need to see the exact beat-to-beat pressure during the hemodynamic swings of positioning, induction, and delivery.
What about a central line?
A central venous line should also be strongly considered, especially if right heart failure or severe pulmonary hypertension is suspected, to guide your microfluid management.
Then there is positioning. I see this missed so often by students, and it is a fatal error.
I cannot emphasize this enough. Left lateral tilt is mandatory. Let's visualize the anatomy. The inferior vena cava and the descending aorta run directly down the back of the abdominal cavity right in front of the spine.
Right.
When a pregnant woman at term lies flat on her back, the heavy, gravid uterus weighing several kilograms physically compresses those massive vessels against the bony spine. This is aortocaval compression.
the consequences of which are disastrous.
It completely blocks venous return from the lower body. Preload plummets, cardiac output collapses, and simultaneously, it blocks arterial flow to the uterus. You must place a firm wedge under her right hip to tilt her 15 to 20 degrees to the left, physically displacing the uterus off the great vessels.
That's a huge deal.
Remember, at term, uterine blood flow is 700 to 900 milliliters per minute. You cannot afford to compromise that flow for even a minute.
Oxygenation and ventilation are next. Pre-oxygenation is vital. Let's explain the physics of why pregnant patients desaturate so fast.
It's a mechanical problem. The enlarged uterus pushes the diaphragm upwards into the chest cavity. This significantly decreases the functional residual capacity, or FRC, of the lungs, which is the volume of air left in the lungs after a normal exhalation.
The FRC is your body's oxygen reserve, right?
Yes. Because it is so small in pregnancy and because their metabolic oxygen consumption is 20% higher, they will burn through their oxygen reserve and desaturate incredibly fast once they stop breathing during induction. You must pre-oxygenate with 100% IO2 for a full 3 to 5 minutes to denitrogenate the lungs.
Fluid management requires military discipline. We aren't hanging liters of crystalloid wide open.
You must use micro-drip sets or syringe pumps. You are administering fluids drop by drop. You want just enough volume to maintain preload and forward flow, but if you give even 200 milliliters too much, you will cause profound postpartum pulmonary edema.
Here's where it gets really interesting. I always get asked about the pharmacological dance of vasopressors. This is where the examiner really tests your receptor knowledge. If the blood pressure drops after you place your block, what do you reach for? The texts explicitly recommend phenylephrine over ephedrine. I want to dive deep into the pharmacology of why.
Let's break down the receptors. Ephedrine is a mixed, indirect, and direct alpha and beta adrenergic agonist. It raises blood pressure by constricting vessels and increasing cardiac contractility, but its beta-1 activity in the heart explicitly causes tachycardia.
And what did we say is the ultimate enemy in MS?
Tachycardia. Shorten a diastole.
Exactly.
Ephedrine will raise the pressure, but the resulting tachycardia will destroy the diastolic filling time and the patient will fail. Phenylephrine, however, is a pure, direct alpha-1 agonist. It binds to alpha-1 receptors on the vascular smooth muscle, causing profound vasoconstriction.
So it raises the SCR.
This maintains your systemic vascular resistance and your aortic driving pressure. But crucially, because it raises the blood pressure so effectively without stimulating the heart directly, it triggers the baroreceptor reflex.
Ah, the stretch receptors in the carotid sinus fire, sending signals via the glossopharyngeal nerve to the brainstem, which fires back down the vagus nerve to slow the SA node.
Precisely. It causes a reflex bradycardia. In almost any other patient, we worry about that bradycardia. But in a mitral stenosis patient, that reflex bradycardia is actively beneficial. It slows the heart rate and prolongs diastolic filling time.
That's amazing.
You're using the physiological reflex as a targeted therapy. Furthermore, modern obstetric anesthesia studies definitively show that phenylephrine maintains fetal pH better and results in less fetal acidosis compared to ephedrine. Phenylephrine is the drug of choice.
That is brilliant, using a side effect as a primary therapy. Okay, choice of anesthesia for the MS pregnant patient. Let's start with regional. We know a single-shot spinal is dangerous because of the sudden, precipitous drop in SVR when the sympathetic chain is blocked. So what do? We don't just abandon regional.
No, regional is still preferred because it avoids the airway risks and the sympathetic surge of intubation. We use the absolute gold standard for these patients, a graded epidural. You meticulously place the epidural catheter. Then, instead of giving a large dose all at once, you administer the local anesthetic very slowly in small fractionated doses over 15 to 30 minutes.
This allows the body time to organically compensate for the slowly ascending sympathetic blockade.
Precisely. It provides a slow, controlled onset of sympathectomy. And crucially, it gives you time. As the blood pressure slowly starts to drift down, you can continuously titrate your phenylephrine infusion to perfectly match the drop in SVR. You get the excellent opioid-sparing pain control of regional anesthesia without the deadly hemodynamic crash of a spinal.
But what if general anesthesia is absolutely unavoidable? Say the patient has a severe coagulopathy, a low platelet count from preeclampsia, or they're actively hemorrhaging from a placenta previa.
If GA is forced upon you, your entire physiological focus shifts to blunting the pressor response to laryngoscopy. You must prevent the catastrophic tachycardia and severe hypertension of intubation.
Do you do that?
You do this by administering generous, carefully timed doses of short-acting opioids like fentanyl, perhaps intravenous lignocaine, or a low dose of esmolol, a short-acting beta blocker, right before intubation. And you must be highly skilled. Your direct laryngoscopy should take under 15 seconds to minimize the mechanical stimulation of the airway.
Let's talk about specific drug considerations.
Yeah.
The examiner will ask you to build an induction plan. First, safe drugs in pregnancy. Aspiration prophylaxis is key.
Yes, due to the anatomical displacement of the stomach by the uterus and the relaxant effects of progesterone on the lower esophageal sphincter, all pregnant patients are considered to have a full stomach and are at high risk for aspiration pneumonitis.
So what's the protocol?
We strictly use a clear, non-particulate antacid like sodium citrate 30 minutes before induction, along with H2 receptor blockers like ranitidine, to raise the gastric pH above 2.5 and decrease gastric volume.
When selecting induction agents and muscle relaxants, what are the deadly pitfalls?
You must explicitly avoid any agent that induces tachycardia. Ketamine is absolutely contraindicated. It is a profound sympathomimetic. It causes the release of endogenous catecholamines, driving the heart rate and blood pressure through the roof. It will kill an MS patient.
What about muscle relaxants?
Pancuronium, an older non-depolarizing relaxant, causes vagal blockade at the muscarinic receptors in the heart, leading to unopposed sympathetic tone and tachycardia. Avoid it completely. Obviously, atropine should be avoided for the same reason. You also want to avoid histamine-releasing muscle relaxants like atracurium. Histamine causes massive vasodilation, dropping your SVR, and triggering a reflex tachycardia.
So what do we actually use?
Etomidate, or a carefully titrated dose of propofol for induction. For muscle relaxation, rocuronium or vecuronium are safe, highly cardiostable, non-depolarizing agents that will not significantly alter the heart rate or blood pressure.
The sources also briefly touch upon the inhalational agents, specifically isoflurane and the risk of coronary steal.
It's a theoretical but highly tested concept. Isoflurane is a potent coronary vasodilator. The theory is that it dilates the healthy coronary arteries, which inadvertently diverts or steals blood flow away from the already maximally dilated ischemic areas of the myocardium that are supplied by diseased vessels.
Right.
Therefore, it's generally used with caution or avoided entirely in favor of agents like sevoflurane, which has a much more favorable profile for cardiac patients. Keep the pharmacology tightly tailored to maintaining a slow heart rate and stable resistance.
We are in the home stretch now. The surgery is successful, the baby is out, and the stenotic valve held up. We can pull the drapes down, extubate, and breathe a sigh of relief, right?
That is the single most common and deadly mistake a junior anesthesiologist can make. You are not safe. In fact, you are entering the most hemodynamically dangerous phase of the entire perioperative journey.
Let's talk about postoperative care and the ICU phase, the auto-transfusion trap.
The immediate postpartum period is incredibly treacherous for a patient with mitral stenosis. Here is the physiology. When the placenta is delivered, the uterus must aggressively contract, clamp down to shear off the spiral arteries and stop the mother from bleeding to death.
Okay, that makes sense.
When that massive muscle clamps down, it physically squeezes a huge volume of blood, roughly 500 to 700 milliliters, out of the uterine circulation and straight back into the maternal central venous circulation. This is the auto-transfusion.
So just minutes after the stress of surgery, you suddenly have a massive, instantaneous spike in preload, hitting a heart with a locked door.
Exactly. And if you weren't incredibly strict with your fluid management during the case, if you gave an extra liter of crystalloid because the pressure was a little soft, this auto-transfusion will immediately overwhelm the left atrium. The pressure will skyrocket, and the patient will be pushed into florid pulmonary edema right there on the operating table as you're waking them up.
That is terrifying.
It is. They need strict ICU monitoring for at least 24 to 48 hours. They require strict fluid restriction and frequently prophylactic post-operative diuretic therapy with furosemide to handle this massive volume load as the uterine blood shifts back to the central compartment.
Oxygen therapy must be continued, and pain control is paramount. We can't let them wake up screaming in pain.
Pain causes a massive sympathetic surge. Adrenaline dumps into the bloodstream, heart rate spikes, diastole shortens, and they decompensate. Multimodal analgesia using epidural top-ups, paracetamol, and very careful titrated opioids is absolutely required to keep them calm, pain-free, and tachycardic-free.
Let's briefly cover maternal and fetal monitoring, especially if the surgery is non-obstetric and occurs prior to delivery.
Fetal well-being must be monitored continuously if the fetus is viable. Fetal heart rate monitoring intraoperatively ensures that your anesthetic management is successfully maintaining uteroplacental perfusion.
If you are watching the monitor and you suddenly see profound fetal bradycardia, what does that tell you?
It is the ultimate distress signal. It indicates that the placenta is failing. This is almost always due to maternal acidosis, severe maternal hypoxia, or severe maternal hypotension. But here's the critical clinical pearl. You don't treat the fetus correctly.
Right.
You treat the mother. Fix her blood pressure with phenylephrine, fix her oxygenation, roll her further onto her left side to relieve compression, and the fetal heart rate will usually recover.
Let's integrate all of this for the exam. This is Part H, comparison and exam integration. The examiners love to ask you to compare MS with other valvular lesions. It proves you understand the specific fluid dynamics of each disease.
You need a clear mental table in your head. Contrast mitral stenosis with aortic stenosis. We spent an hour building the MS profile. For MS, your mantra is slow, full, and tight. Slow heart rate to allow diastolic filling across the narrow valve. Full but carefully optimized preload to maintain the pressure gradient to push blood through, and tight SVR to maintain aortic pressure for coronary perfusion.
But aortic stenosis is a completely different beast mechanically. The obstruction is at the exit of the left ventricle, not the entrance.
Exactly. Aortic stenosis also strictly requires a slow normal sinus rhythm and a tight SVR to perfuse the massive muscle. But because the left ventricle is pumping against a rock-hard aortic valve, it becomes massively hypertrophied, becomes thick and incredibly stiff.
So it needs more pressure to fill.
Therefore, it needs an extremely high preload of very high filling pressure just to stretch that stiff ventricle enough to accept blood. If you drop the preload in AS, the ventricle collapses. The Goldman Risk Index specifically flags significant AS with a gradient over 50 as a major perioperative risk, just like severe MS grid. Knowing these distinct, contrasting hemodynamic profiles shows true consultant-level mastery.
Let's run through some rapid-fire common exam questions and Viva traps. We've hit a lot of these naturally, but let's review them explicitly. Doctor, why not just do a subarachnoid spinal block for this cesarean?
Because, examiner, a spinal block causes a sudden, unpredictable, and profound sympathectomy. This leads to a catastrophic drop in systemic vascular resistance and venous return. In a patient with a fixed cardiac output who cannot reflexively increase flow to compensate, this will result in profound, irreversible hypotensive arrest.
Doctor, the patient's heart rate is 110 on the ward. I want to induce with ketamine because it supports blood pressure. Why is that wrong?
Because ketamine is a powerful sympathomimetic that causes the release of endogenous catecholamines. It will drive the heart rate to 130 or 140. This catastrophic tachycardia will critically shorten diastolic filling time, prevent the left ventricle from filling through the stenotic mitral valve, drop cardiac output to near zero, and cause flash pulmonary edema. It is absolutely contraindicated.
What are the common student mistakes you see that result in immediate failure?
Number 1, allowing tachycardia at any stage, failing to treat a heart rate of 100. Number 2, careless fluid overload. Hanging a bag of saline wide open and forgetting the deadly post-delivery auto-transfusion trap. Number 3, ignoring aortic valve compression by forgetting to ask for the left lateral tilt wedge. If you don't tilt the patient, you fail.
If you want examiner-approved, safe, high-scoring answers, constantly weave these phrases into your Viva. I'll utilize a multidisciplinary approach involving cardiology and high-risk obstetrics. My primary goal is strict heart rate control to maximize diastole. I will employ meticulous, drop-by-drop fluid titration. And my anesthetic of choice is a carefully graded epidural.
Use that vocabulary and you own the room.
Let's talk about the written paper. Diagrams and exam presentation. When you get a 10 or 20 mark question, don't just write a massive, unreadable wall of text. The examiner has 100 papers to grade. Make yours beautiful.
Draw. Draw out the MS pathophysiology flowchart right in the middle of the page. Start with narrowed valve area, arrow to increased LA pressure and dilation, arrow to atrial fibrillation and loss of atrial kick, arrow to pulmonary venous congestion, arrow to pulmonary edema and right heart failure. It takes 30 seconds to draw and proves instant comprehension. Draw a simple schematic of the pregnancy hemodynamic changes showing the vectors of volume going way up and SVR going down.
And structure your answer logically, using clear headings. Start with an introduction and the pathophysiology. Move to preoperative assessment, explicitly mentioning MPs and NYHA class. Outline your intraoperative goals and required monitoring. Detail your choice of anesthesia and specifically justify your drug rationale. And finally, emphasize postoperative care and the auto-transfusion risk.
That structure is impenetrable.
To wrap this up, let's do a rapid-fire, high-yield, bullet-point recap of the golden rules for mitral stenosis in pregnancy. Rule 1. Prevent tachycardia at all costs. You must maximize diastolic filling time.
Rule 2. Maintain strict sinus rhythm. The loss of the atrial kick in AFib is devastating.
Rule 3. Use a graded epidural for labor and delivery to ensure a slow, stable drop in SVR rather than a crashing spinal.
Rule 4. Position the patient with mandatory left lateral tilt to prevent aortocaval compression and maintain uteroplacental perfusion.
Rule 5. Keep PUV fluids incredibly tight and aggressively anticipate the 500 milliliter postpartum auto-transfusion.
Rule 6. Use pure alpha agonists like phenylephrine to treat hypotension, specifically utilizing its reflex bradycardia, and explicitly avoid ephedrine.
And here is a model conclusion paragraph you can memorize and write at the very end of your exam essay. Quote, in conclusion, the successful anesthetic management of a pregnant patient with mitral stenosis relies on a delicate, multidisciplinary balance. Strictly preventing tachycardia to optimize diastolic filling, meticulously titrating fluid to avoid postpartum pulmonary edema, and providing a slow, graded regional block to maintain systemic vascular resistance while ensuring optimal uteroplacental perfusion and fetal well-being. End quote.
That is a mic drop conclusion paragraph.
It really is.
I want to leave you with one final thought. If we connect this to the bigger picture, we spend so much time in our textbooks focusing on the mechanical flow of blood through that narrowed valve. We calculate pressure gradients, we measure pulmonary capillary wedge pressures, we argue over the exact drip rate of our fluids.
Right.
But consider the reality of the laboring mother. Consider how the profound emotional and psychological stress of labor, the fear, the pain, acts as a massive endogenous catecholamine infusion. The terror releases adrenaline, which drives the heart rate up just as dangerously, just as lethally, as if you had injected the wrong drug. This raises an important question for your daily practice. How does your bedside manner, your calm, authoritative voice, your thorough psychological preparation of the mother physically alter her hemodynamics and ultimately her survival? Empathy, clear communication, and trust in the operating theater are not soft skills. In a patient with critical mitral stenosis, empathy is a profound life-saving hemodynamic intervention.
Empathy as a hemodynamic intervention. That perfectly encapsulates the art and the science of what we do. Well, to our dedicated Gujarat University MD anesthesiology student, we hope this deep dive has armed you with the best evidence, the clearest understanding of the pathophysiology, and the sharpest exam strategies. You have got this. Keep studying, keep synthesizing those systems, and remember that initial X-ray analogy, the waters of complex physiology, might be murky, but with the right monitoring, the right pharmacological logic, and the right preparation, you can see right through them. Thank you for joining us, and we will see you on the next deep dive.